students, let me move on to the next topic of the symposium, that is assessment of the severity of the ANCA-associated vasculitis and kidney diseases. Because it's very important to assess the severity, that would give us the prognosis as well as the therapeutic options. So to cover this topic, may I request Dr. Sriharsha Gurram from Karnataka to please come to the stage and take over, please. I request all the speakers to please stick on the time.
Thank you, madam. I'm Dr. Sriharsha, consultant nephrologist and transplant physician from Manipal Hospitals, Hebbal, Bangalore. Before beginning my talk, I would like to thank the organizing committee, Dr. Swanlata madam, Dr. Ravishankar sir, and ISN South Chapter to provide me this opportunity to speak here. So, diving straight into the topic, I'll be dealing with the topic of assessment of severity of ANCA-associated vasculitis and renal disease. So, I'll be covering this topic under following headings: introduction, what are the symptoms of severe ANCA-associated vasculitis, the tools available to us to measure the disease activity, and followed by how we assess the renal severity, and I would conclude after that. So, we know that renal involvement varies in the degree of its severity. If at all there is renal impairment at the time of diagnosis or presentation, it predicts poor renal and patient survival. The main data for Europeans for the ANCA vasculitis is from Europe, because the disease is more common in the northern Europe and the upper latitudes, the Caucasian race. So the European Vasculitis Society trials has shown that eGFR of less than 50 ml per minute is associated with 50% risk of either death or end-stage renal disease in 5 years. So that's a very high number. Overall, ANCA contributes only up to 1% of the ESRD cases. However, as we know and as we have learned during our study days, that it is one of the most common cause of RPRF or so-called RPGN. So the NIH data also suggests that there is only 18% of patients who present with renal involvement initially. That is more so with GPA, that is the granulomatous polyangiitis, and the EGPA. However, the MPO positive or the microscopic polyangiitis do present with renal involvement upfront. However, during the course of the disease, within first 2 years of onset, about 85% of the patients do develop some or the other kind of renal involvement. It progresses rapidly if untreated, and as we already discussed, can lead to organ threatening or life threatening disease. MPO ANCA patients who have MPO positive ANCA present more with renal involvement and RPGN compared to granulomatous polyangiitis. When the patient comes to us, the clinical history and the initial lab values will suggest to us that there is some kind of RPGN going on. And if we do an ANCA serology, it might very well come out to be positive, and our diagnosis is almost certain. But we do require renal biopsy. Why do we require it? We have to delineate the prognostic criteria and form a prognostic criteria to delineate the patients. So ANCA, as lupus, ANCA also affects all the systems in the body. Initial symptoms are always constitutional, like general weakness, malaise, maybe some swelling in the legs, or some aches and pains in the body, or joint pains. Here the important thing to be noted down is extra renal manifestations are more common or initial presentation in EGPA or GPA, that is the vaginal granulomatosis or the eosinophilic granulomatosis. However, MPA, that is a microscopic polyangiitis, presents mainly as a kidney involvement. All other organ involvement are as a presenting feature for the other GPA. So whenever a patient comes without any major symptoms, probably some constitutional symptoms and RPRF, we have to think probably it is an MPO kind of a vasculitis. How it is important, I would be covering it in the later slides. So the European League Against Rheumatism has divided the presentation into 5 categories, that is the localized, early systemic, generalized, severe and refractory. Localized is where there is just symptoms without any systemic upper or lower respiratory disease or any other systemic involvement, like probably small skin involvement or proteinuria with constitutional without having any life-threatening or organ-threatening symptoms. In early systemic disease, without any organ or life-threatening disease, there are systemic features, that is multiple organs are involved at presentation, maybe muscles, maybe cardiac, maybe skin, and of course the kidneys. When the disease is generalized, we do have an RPRF presentation with high rise of creatinine, proteinuria, and severe disease is when creatinine is above 5.7 milligram per deciliter or 500 micromoles. We call it a refractory disease when there is a progressive disease despite treatment. So how do we say that the ANCA vasculitis is severe? Our common presentations like acute glomerulonephritis and diffuse alveolar hemorrhage or pulmonary hemorrhage is what we know. However, the rarer the organ involvement, that is, we don't generally see involvement of CNS, involvement of cardiac tissue or eyes or GI involvement as a usual presentation. If they are present at the time of diagnosis, it means that the disease is severe. So the disease is so severe that even the rare form of presentations are also appearing. So cerebral vasculitis, involvement of the eyes, scleritis in the form of scleritis or orbital pseudotumor, GI bleeds or mesenteric ischemia, and cardiac disease due to vasculitis in the form of pericarditis or myocarditis. All these show us that the disease is severe and requires aggressive management. What are the tools we have to measure disease activity or disease severity? Birmingham Vascular Activity Score versions 1, 2 and 3 are available to us. It is a activity score which has 66 clinical features divided into 9 organ groups. It was first initially developed in 1994 and the versions came about subsequently, and the latest version which we are using is the BVAS 3, which was developed in 2003. In between there was another score called BVAS WG, that is vaginous granulomatosis, which was only used in GPA patients. However, the crossover didn't happen. The score which was developed for GPA did not translate or did not match up to the patients who have EGPA or MPO. So another score is the vascular damage index or VDI. So BVAS or the Birmingham Vascular Activity Score tells us what is active, what are the organs which are actively involved at the moment. Our vascular damage index helps us to differentiate symptoms based on the damage. Damage here refers to an irreversible or a scar forming disease which is present at the time of diagnosis. More the damage at presentation, poorer the patient outcomes. Disease extent index and 5-factor score are some other derivatives of Birmingham Vascular Activity Score, basically to differentiate or to complement the BVAS rather than replace it. So as I discussed, the first BVAS score sheet had come about in 1994 and the latest version in 2003. It helps us in making clinical decision making regarding the therapy. More importantly, it allows us to compare different groups of patients in different centers using similar protocols for comparison of different treatments. So all the vasculitis treatment groups or the newer molecules, all which have been tried about, use BVAS as their clinical model or the clinical score. Based on clinical score, they apply their therapy. It also helps us in evaluation of long-term patient care. So after treatment, we can recheck like a checklist what symptoms have been better or what symptoms are still ongoing. So in that way, it helps us in long-term patient care, and it is predictive of short-term and medium-term mortality. As I told, renal involvement at present or diffuse alveolar hemorrhage, which might require a form of therapy of plasmapheresis, itself says to us that the disease is severe. So, or it can be a life-threatening disease. So, it has a value in short-term and medium-term mortality. So, this is the score sheet which is there, 9 organ groups, and the next 2 sheets are the scoring system. It requires certain amount of training because it is a complex thing, but the only thing which I would like to highlight in this busy slide is the renal scoring. The 8th one is the renal score, where the maximum score is given to a renal involvement where the creatinine is more than 5.7. The BIVA scoring has been well established in over more than 10 published therapeutic trials on vasculitis by various groups in the past 5 years in the Northern Europe as well as in the US. It is a standard disease activity measure in clinical trials in patients with vasculitis. Each organ has minimum score of 1 and maximum score ranges from 3 to 12. The highest score, as I already mentioned, is for the kidney involvement, where the creatinine is more than 5.6 at the onset. Higher the score, worse the outcome. Simple to decipher. Higher the score, worse the outcome. In various studies, cross-sectional and retrospective studies, it has been shown that higher BIVA score was associated with higher mortality or a worse outcome. So the vascular damage index, it is also, as I told, irreversible damage which can occur at the presentation, and it is defined as a non-healing scar that is unlikely respond to the immunosuppressive treatment. It is also made up of 64 items grouped into 11 organ-based systems. So this is the scoring sheet. Early damage is a predictor of mortality, and various studies have proven that. Coming to the renal severity, how bad or good is the renal involvement? What are the factors which we have to look into? The baseline GFR or the baseline creatinine, age of the patient, older patient translates to inferior renal and patient survival, MPO-ANCA subset of patients, and definitely the histopathology, which shows, which according to the involvement or the type of involvement may show normal glomeruli or chronic diseases. So it has been shown that MPO-ANCA has worse renal survival or patient survival because there is severe disease at the onset. And there is also a concept of smoldering disease in MPO, where there is a slowly progressive disease which is happening in the kidneys, but which is not very evident. But by the time it is evident, the damage has already been done. So that is more commonly seen in MPO subset of patients, not in the GPA or the EGPA patients. So histopathological grading is done by Burden et al., or which is called as International Pathology Classification. Bertie et al. In Chronicity Index, or also called Mayo Clinic Index or Renal Pathology Society, and Briggs et al., who have given a renal risk score which is based upon pathology, the histopathology and the clinical data. So the Burden classification or the International Pathology Society classification shows that there is focal class divided into, the histopathology is graded into 4 things: focal class, crescentic class, sclerotic, and the mixed class. Focal class, where there is more than 50% normal glomeruli in the biopsy specimen. The sclerotic class has more than 50% globally sclerotic glomeruli, and the crescentic class also has more than 50% of cellular crescents, either segmental or globular crescent. So focal class has been shown to have better prognosis, obviously because there are more number of normal glomeruli, and sclerotic class because the damage is high.
Can you please mind her?
Yeah. One moment. And sclerotic class has been shown to have the poorest outcome. So this is the histopathology pictures, and it has been very well validated. His international pathology classification has been very well validated in different subgroups. The only pitfalls of this classification is that it has not taken into consideration the non-glomerular component, that is the interstitium and the tubular compartment. This is where the other classifications or the scoring systems in chronicity and the renal risk score comes into being. So to conclude, I would say that in ANCA vasculitis, standardized clinical tools and histopathology classification or scoring helps us in assessing the disease activity, damage and the function, assist in evaluation and help to justify our treatment decisions, provides prognostic information, and most importantly, provides us a tool for standard disease assessment, which is very important for the evidence generation. There are no universally applicable serological markers. And this application of this course requires some training, experience, and continued development and refinement. Thank you.